The Ohio Psychological Association's Education Committee would like to welcome you to Autism Spectrum Disorder and Racial Minorities, the Impact of COVID-19 on Treatment, Access, and Delivery, a virtual workshop presented as part of our 2021 annual convention. OPA is an approved CE sponsor of the American Psychological Association and maintains responsibility for the program and its content. OPA is also an approved CE provider of the Counselor, Social Worker, and Marriage and Family Therapist Board of Ohio. This session has been approved for 2 continuing education credits in ethics. Instructions on how to receive CE credit will be covered at the end of this workshop and are available on our website at www.ohpsych.org. At this time, I'd like to introduce our speakers. Kathleen Cruse-Grasser, a licensed professional clinical counselor, serves as clinical lead supervisor of the Autism Outpatient Psychotherapy Program at Nationwide Children's Hospital Center for Autism Spectrum Disorders. Kathleen has provided outpatient behavioral and mental health treatment to children and adolescents with autism spectrum disorder for 9 years. Prior to working with this population, Kathleen treated adults and adolescents in an intensive outpatient program for substance use disorders in Boston, Massachusetts. Kathleen supervises clinicians using modified CBT with children and adolescents with autism spectrum disorders. Working with children and adolescents who are impacted by autism and trauma is an area of specialty in her current position. Dr. Karen B. Tabern serves as psychology supervisor of the Autism Outpatient Psychotherapy Program at Nationwide Children's Hospital Center for Autism Spectrum Disorders. Dr. Tabern provides supervision, training, and oversight of behavioral health services provided to children and adolescents diagnosed with autism. Additionally, Dr. Tabern provides education and training on cognitive behavioral therapy. Dr. Tabern also has experience in providing trauma-specific treatment to children and adolescents using trauma-focused cognitive behavioral therapy and is trained in dialectical behavior therapy. She continues to support efforts to prevent trauma and suicide in children and adolescents with autism in her current position. Now it's my pleasure to turn over the workshop to our speakers. Welcome.
Thank you so much for attending our presentation today. We are going to be talking about autism spectrum disorders in the racial minority community, and with respect to the impact of COVID-19 on treatment access and delivery for these populations. I am Kathleen Cruse-Grasser. I'm a clinical lead supervisor and also a behavioral health outpatient therapist at Nationwide Children's Hospital Center for Autism Spectrum Disorders.
All right, I am Karen Tabern, and I'm a clinical psychologist and the psychology supervisor for our outpatient psychotherapy program at the Nationwide Children's Hospital Center for Autism Spectrum Disorders.
I do want to just note that we do not have any conflict of interest or disclosures for our presentation today. But one little disclaimer that some of the topics that we will be discussing are sensitive. So if they bring up any emotional responses for you and you need to take some time away, please do that and take care of yourself. So 2020 was appropriately deemed the year of change. So about a year ago this month, we were caught in this nationwide global pandemic that led to quarantining across the country, and that really led us mental health professionals scrambling to adapt and provide a safe and accessible way of treatment for our clients. This was new for all of us. We at Nationwide Children's Hospital had not used telehealth before, especially for outpatient therapy with children with autism spectrum disorders. So this was very new, but also exciting because it provided this new access point for kiddos on the spectrum who needed a diagnosis and treatment. Also in 2020, we ran into a lot of really big, important movements like the Black Lives Matter movement. that spotlighted and magnified systemic racism yet again in our country. And we're all forced to kind of stop and look and reflect at our current practices and how we might be engaging in an implicit bias and not really paying attention to our own part of that system and structure. So this really led Nationwide Children's Hospital to declare systemic racism as a national health crisis that we needed to address in our community. So as a result, us at the Center for Autism Spectrum Disorders, we really wanted to reflect on our current practices, and we wanted to look to improve access to and quality of care for our minority populations that we serve in the community. We wanted to see if telehealth made a difference in our access to care to that community. And we're going to be looking at this in numbers of completed appointments eventually, but we really are going to be focusing on the racial minorities. So with our presentation today, we hope that you come away with the ability to describe barriers to diagnosis and treatment of diverse individuals with autism spectrum disorder. And we want you to be able to discuss the benefits of telehealth with children and adolescents with autism spectrum disorder. And lastly, we hope that you'll be able to identify barriers of minority groups in accessing mental health services and be able to describe the benefits of telehealth services for this population.
All right, so to begin us off, I'm going to give a broad overview of the Center for Autism Spectrum Disorders here at Nationwide Children's. We are a multidisciplinary program that's comprised of several teams that provide comprehensive autism-specific interventions from birth through young adulthood. And we provide services in clinic, at the outpatient level, and also in the community and community-based settings. So I want to talk a little bit about being co-located with some very other important departments and clinics. We are co-located with our Child Development Center, and this is our group of folks who really are focused on the diagnostic assessment and evaluation of our kids with developmental disabilities, including autism, and also providing that initial and most critical care coordination directly following a diagnosis. Our Child Development Center is often one of our most common referral sources after a client is diagnosed with autism and being referred over for much needed treatment. We are also, in our particular location, co-located with speech therapy. So some of those really essential clinical therapies that take place for our kids with autism. We also, within the hospital system, have access to other clinical therapies such as occupational therapy and physical therapy and other specialty care that our kids may really need. Additionally, we're co-located with psychiatry services that provide a lot of our medication management. Our psychiatrists are focused on the treatment of autism spectrum disorder and have expertise in this area, and so really provide a valuable and often essential service to our kiddos. So in terms of thinking about kind of the box here in the center with the different colors, that's the Center for Autism Spectrum Disorders. So we have our behavioral intervention program, which is really our early intervention team that's using applied behavioral analysis as our model for evidence-based care. We have a toddler program to treat our youngest individuals with autism. We also provide school-based services. And this program really focuses on functional skill building, parent training, behavior support, and school consultation for our kids. And within the behavioral intervention program, we also have a transition services team that work with our adolescents with autism who are transitioning into adulthood. And Of course, skill building continues to happen and is important, during this phase of development, but we are also helping them build vocational skills. We're providing consultation to their families and to other providers on their team. We're providing care coordination, and we're also helping the family access resources, help the child or adolescent build independence. And we're also helping guide the client and the family in that transition from pediatric care into the adult healthcare setting, which we all know is a very critical time because those two healthcare systems tend to be very different. Down in the green, you can see our complex behavior program. This is our team that provides behavioral intervention to our clients with autism who exhibit significant or severe problem behaviors that pose a risk, safety risk to themselves or to those around them. And the focus of this team is, one, to reduce problematic or dangerous behavior, but also, two, and equally as important, to promote and build adaptive functional behaviors. They provide direct behavioral intervention, parent training and support, and care coordination. They also provide interprofessional training when our kiddos with autism have maybe home care providers, or they're working with a school to develop a behavior plan. One of the things to note with this particular team is they do provide in-clinic services. They provide outpatient level services, community-based services, and we also have an intensive day treatment program that is a progressive model from in-clinic to community-based to help the generalization of the skills that are learned there. In the blue here, we have our outpatient psychotherapy program. So this is the program that Kathleen and I referenced to as kind of where we come from and the team that we serve on. And this is our team that provides our mental health services or autism-informed psychotherapy services to our kids with autism. And we provide intervention primarily coming from that cognitive behavioral therapy model. And we do that in an individual, group format, and family therapy format. So we also work on social skills training, functional independence. We kind of cover all those different needs, but our focus really comes from that mental health background. We also provide parent training, school consultation, and care coordination services. In kind of this red, peach, pink, salmon colored box at the top is our community outreach program. So this really is comprised of lots of individuals, maybe across these different teams that really are providing work with external agencies, providers, schools, stakeholders in the community. We're providing education and training and advocacy related to autism and to our clients' needs. Across the center here is our resource support, which is, we call our autism resource clinicians. They are really essential to all of our teams and to our families. They are really responsible for our referrals and triaging families into the most appropriate program and setting them up for success as they enter into care by gathering information and trying to assist them in going first to the program that we think might best meet their needs. But perhaps if there are additional needs, then during their intake appointment, we can, connect them with some of our other programs. They also provide resources and care coordination to our families, and are also engaged in clinical care at times, providing parent training and consultation. Next slide. All right, so I'd like to think a little bit more about autism specifically, and I'm going to give just a broad overview of the diagnostic criteria that we are considering when we're making a diagnosis of autism. I will not kind of read all the details outlined in the DSM. But just wanted to orient those that may be less familiar with a diagnosis of autism to some of the key things that we're looking for. So the two core symptom areas that kind of make up an autism diagnosis include deficits in social communication and social interaction, as well as restrictive, repetitive patterns of behavior. So we're looking for symptoms and impairments in both of those areas. Some of those symptoms and impairments must be evidenced early on in development, typically beginning in early childhood. So it has to be there, kind of some evidence of it across childhood. For a diagnosis of autism. And each of those symptom areas, we are giving a severity rating. So you can see there the levels of severity 1 through 3, with 1 requiring the least amount of support in a certain area, all the way through requiring substantial support in a particular area. And so when making a diagnosis, a clinician is going to give that level of support, like I said, in each of those specific areas. Also, when making a diagnosis of autism, we will also give specifiers that indicate whether or not a child is experiencing any intellectual or language impairments in addition to their diagnosis of autism. So you can see there's a lot of information about a child that comes from just understanding their complete diagnosis. One of the things, though, that is particularly important when we're thinking about a diagnosis is that the severity and the range of symptoms can vary greatly across the individual and contribute to different areas of strength where a child may be performing average or even significantly above their same age peers in certain areas, and they may have other areas of deficit where they are falling below or their same aged peers and exhibiting less functional skills there. So what that creates is what we call kind of like a splintered profile, where the kiddo can sometimes demonstrate very high level of skill in one area and very low skills in another. And so when making a diagnosis of autism, it really requires a complex conceptualization of the assessment of the child, and then also as we think about them moving forward into treatment and what their treatment needs are. You can go to the next slide. All right, so some statistics about autism. The prevalence rates of autism continue to rise over time, and specifically in the last several years, we've seen a dramatic increase. Our current prevalence rates for autism are 1 in every 54 children are diagnosed with autism, and autism affects 4 times as many boys as girls, although we know that historically there has been underdiagnosis and underrepresentation of girls in the autism population. We are learning to understand how symptoms of autism present in girls, which has led to more accurately identifying them and diagnosing them with autism, which has been an important improvement in our field over time. However, despite an improved diagnostic rates, that is not the sole reason we're seeing such an increase in the prevalence of autism. So we also know that there are still variables and potential causes of autism that are not clear or even unknown, at this point. The last data point here on the slide is that 85% of children diagnosed with autism have a comorbid mental health diagnosis as well. Some of those most common diagnoses being ADHD, anxiety, and depression. I think this is a statistic that is very relevant to our presentation and what we'll be talking about today. Given that Kathleen and I are clinicians overseeing and providing mental health services, but also just in thinking about the impact of the global pandemic on mental health functioning. You can go to the next slide. A minute on age of diagnosis. So the age at which a child receives a diagnosis of autism continues to be essential to that child accessing care and receiving the treatment for the symptoms and deficits related to autism. The earlier that the intervention can take place, the better the long-term outcomes for the child with regard to functional living, social emotional development, and adaptive skills. So with that, the American Academy of Pediatrics recommends that screening be done for autism spectrum disorder in the pediatric medical setting, both at the 18 and 24-month well visit. So standardized screening during this time provides an opportunity to evaluate a child at an age where lots of critical skills can be assessed. So things like language, social interaction, behaviors that we may think are pretty indicative of autism. So all of these things can be evaluated during that time. And what the literature is suggesting that when those screens take place in that age window, those children that are screening positive at that 18 or 24 month are actually receiving a diagnosis earlier in development, which is important. So I think it's also notable, though, that the median age of an autism diagnosis continues to be around 4 years old. And as we will learn moving forward, that the diagnostic age for autism is typically delayed for our racial and ethnic minority groups, but also for children who may not present with significantly notable symptoms or impairments, or who may be achieving developmental milestones within what's considered normal limits. So again, taking a look at that splintered profile. So those kids where things are a little more subtle also have a delay in their their age at diagnosis. All right, the recommended treatment for autism is intensive early intervention. As I mentioned before, applied behavioral analysis is the model that we use at the Center for Autism Spectrum Disorders, and it is an evidence-based practice. It involves behavioral intervention designed to increase, like I mentioned, those functional skills, but is also used then to modify behavior. Early intervention, has shown to make lasting improvements in a child's overall learning and IQ, social skills and communication abilities, enhance social emotional functioning, and increase self-help. It also has been effective at reducing those behaviors that contribute to greater impairment, may be inappropriate, or may pose safety concerns. The American Academy of Pediatrics recommends applied behavioral analysis as the evidence-based treatment and primary treatment for our youngest population of kids diagnosed with autism, which is birth to 3 years old. This is in order to achieve best outcomes over the course of the child's life. Now I'm going to turn it over to Kathleen, who is going to take us a little deeper into health equity and help us to begin to explore the disparities that exist for our racial and ethnic minority families in the autism population.
Thank you. Yes, health equity is a topic that is increasingly mentioned in health articles and increasingly researched in the healthcare community. If you do a search, a title search in Google Scholar of health equity, there's a ton of articles that pop up researching this topic. Health equity, there's a great definition from the CDC, and it means that everyone has the opportunity to be as healthy as possible. Equitable opportunity includes equal access to and distribution of resources. And when policies, programs, and systems that support health are equitable, poor health outcomes can be reduced and health disparities can be prevented, as well as the whole of society benefiting. And this is really what we are going to be focused on today, is this health equity and the idea of reducing health disparities. We can address our biases in science and explicitly take on social injustice in the healthcare field, but to fully encompass and understand the knowledge of health equity means not only to accept that everyone, including marginalized communities that we'll be talking about today, but it also includes a commitment to fair practices across a variety of areas, including education, housing, transportation, beyond just healthcare. When we're assessing our own practices in our field, we really are challenged to think about how our own efforts to reduce health inequities are going to help our current practices moving forward. So it's important to consider how the gap of healthcare has widened for specific populations in order to really guide us in reducing these inequities in our current practice. And we're going to mainly be focusing on here, excuse me, the history of racial health inequity in the African American population in our country. Race and racism are important factors in our healthcare system, and these aren't always acknowledged. But from the beginning of America's healthcare system, race has played a major role in clinical decision-making, and it's contributed to an African American health crisis that we're still seeing the remnants of today. We continue to see the perpetuation of discriminatory barriers to African Americans who are entering the field of healthcare professionals, as well as unfair and abusive medical treatment. So we're gonna head on back to the 17th century. And this was really where the racist underpinnings of science began. This was when enslaved Black people entered America for the first time through the slave trade. We see at the heart of science and medical treatment, the beginnings of racist, abusive treatment toward Black people. They were seen as a different species. They were deemed subhuman based on just biophysiological characteristics, nothing more. So we see white medical figures relying heavily on the use of Black subjects for medical experimentation for things like dissection, surgery, and bedside demonstrations. This practice was really driven by lack of medical treatment for common diseases at the time. So they really didn't have a lot of advanced treatments and medical practices. So they used Black slaves as subjects for their exploitation. That really began the horrific history of abuse to enslaved Black people and African Americans moving forward, as Black people would present with ailments and sicknesses, and this was viewed as malingering, and frequently was met with corporal punishment. So as we move into the Enlightenment period of the 18th century, this was, again, the early racist and abusive medical practices of the 17th century flooded right into the 18th century and really took stock in this century as racist theoretical sciences grew. Instead of ideas of freedom from superstition or rational thought toward progress, that was the whole idea behind the Enlightenment period, and that liberty was seen as a natural human right, and reason and scientific knowledge would be responsible for human progress instead of dictations from the state or church. However, of course, this did not apply to Black, Indigenous people of color. Instead, the race theory, which was perpetuating the ideas that the Black race was less evolved than European whites, this was really fully ingrained in science and medical practice at this time. Individuals like Johann Friedrich Blumenbach, he was a German anthropologist at that time. He began the human classification system by race. This really just justified and continued the exploitation of Black, Indigenous people of color around the world by European white colonizers. And the only real contact that enslaved Black people had with medical treatment at the time, it centered around exploitation and experimentation, unfortunately. And we will see this continuing to be that through line through the centuries of African Americans engaging with the medical field, and this breeding of a lack of trust in medical science that is rooted in some of these exploitation practices. By the 19th century, the European-founded race theory had been well established. So this was, again, the line of thinking that justified and defended slavery in America, in the US, and around the globe. The American School, it was the first American scientific movement that was made up of and led by white American medical professionals. And it promoted the idea that there is a separate creation of race in mankind, and that Black people or the Black race had a biological inferiority to whites or European whites. This was the underpinning and the guide for pushing segregation in hospitals eventually. And it had major implications in quality of care that Black people had received. At the time, Black poor health was accepted as the norm, and white American physicians attributed many common diseases as Black diseases. Many of these stemmed from the poor and abusive living conditions of the time, and they had poor access to nutritious foods. So for example, a form of tuberculosis that was transmitted to America out of Europe was characterized as the African disease. And they would frequently diagnose exclusively Black diseases to enslave Black people for things like not showing enough enthusiasm for slavery, or for a behavioral malady that was characterized by a desire to destroy the property of white slave owners called dysesthesia ethiopica. Black slaves who would eat clay and chalk and dirt were said to have what we know as pica today due to malnourishment. So unfortunately, these ailments were commonly treated with corporal punishment and seen as not real, or just chalked up to, oh, well, that's just the norm. By 1865, we see that slavery is abolished, but we know that slaves who were free didn't actually have access to quality health care, and were not free from medical abuse or systemic racism. And in fact, the Black health status remained the poorest of any racial or ethnic group in America. By the late 19th century, the medical field was starting to become a prestigious and respected field as medical practice became more standard and advanced. During this time, we also see the rise in figures like Charles Darwin, who brought evolutionary theories to the forefront. But again, as we know, evolutionary theories just really solidified their racist beliefs and this false science that Black people were inferior and less evolved in the social and natural sciences. And of course, when slavery was abolished, we know that there are legal practices that really intervened to help can maintain or continued some sort of classification system to keep African Americans lower than white Americans. And we see this with, in the 1870s, the American medical profession enacted a policy that officially racially segregated Americans. And this allowed African Americans to be untreated for health ailments or to be treated in really substandard facilities. Some of the only facilities that treated Black people as human were Black hospitals and clinics. Of course, these were very underfunded and were hard to come by. At the start of the 20th century, most of American medical schools and health professions, they were segregated still. And the Northern Black population had varying access to inferior, tax-supported Black hospitals. And Black people in the South were straight up refused service at proper health facilities. So as we begin this 20th century with segregated hospitals, and we still have schools working from the perspective, medical schools, I should say, working from the perspective that African Americans were a syphilis-soaked race and inferior. African American doctors were restricted from getting into the field to even be a part of the system that could serve their population. Black underrepresentation in the medical profession rose to 2% levels around 1900 and remained there until the 1980s. During segregation in the South, it was still Black people were being turned away from white hospitals that were reserved for whites only, or sometimes they would be served in the basement of those hospitals. And in the North, white physicians were pressured to turn away Black patients and could be treated as medical training as subjects of experiments. So that was one of the only ways that Black people could get treated, was through medical training as experimental subjects. This leads us into the early 1930s, and I know many of us have heard of the Tuskegee syphilis study. This was a horrific exploitation and abuse of Black men in the South, and so I'm just going to go into it a little bit more in detail so we can see the extent of how horrible it was. And it was an experiment that was funded by the U.S. Public Health Service, and originally it promised medical care to about initially 600 sick, desperately poor sharecroppers in Macon County, Alabama. The Public Health Service said this was a study designed to study the progression of syphilis in Black men. The underlying assumption was that syphilis manifested differently in white people than Black people. So again, this idea that is ingrained in medical science that Black people and white people are inherently physiologically different. This led to exploitations like this. They found a pool of infected Black men and they withholded treatment from them. They were charting the progression of the disease from beginning to eventually death for some individuals. The public health system, of course, lied to these subjects and convinced them that they were being treated and not studied. Then when the men ultimately died, the physicians and researchers would autopsy their bodies to see how the disease manifested. The study was disguised as a treatment program, but they were ultimately left untreated. And just to give you an idea, the virus wreaks havoc on the cardiovascular and neurological systems over the course of decades. So this is a long, prolonged illness that has really severe deleterious effects on the body that can eventually lead to death. And that's what these men really thought they were being treated for. And the quote unquote treatment that they were given they were just given vitamins. They were given doses of arsenic and mercury. And these have severe side effects on their own, including injury to the nervous system, mental deficits, hair and tooth loss, kidney, heart, and lung disease. And the thing is, at the time, there was treatment available for syphilis, but the doctors withheld this treatment to track this disease over the course of 4 decades. And by the time it ended in early 1972, It was brought to light by the media, and so the Public Health Service ended the study, but there wasn't a formal apology to survivors or family members impacted by the study until 1998 by President Clinton. In the 1960s, desegregation of hospitals and medical practices, they were pushed by the passage of Medicare and Medicaid. So with this law passage, hospitals could not get federal funding if they practiced racial discrimination. Before this, though, Black people would be refused service at hospitals reserved for whites, as we know, but Black people continued to fall into traditional roles of mostly engaging with medical professionals in an exploitative way through medical training or clinical research. So we've just continued to see this pattern of that a gigantic barrier and huge mistrust of the medical community, given everything they've encountered with the medical system over time. With Medicare and Medicaid funding, though, it really did open up communities to better health programs, and sometimes the only health programs that they'd been engaged with, and increase access to health care. And there's a huge push for political powers at the time to federally fund other programs, including housing and education. And the thing is, though, as these programs did advance, they eventually plateaued. Though during the advancement period, there were significant improvements in African American medical health at the time. But as those advancements plateaued, the health progress of African Americans also plateaued. And this deteriorated into the 1980s and continued deteriorating from there, as we see with significant morbidity and mortality rates in the African American community. So now we're into the 21st century, and we still have a significant number of African Americans who remain demographically, economically, and socially segregated within our nation's inner cities. And we know these places continue to be underserved and exposed to substandard healthcare. And we see there's a systemic review focusing on cardiac care. African Americans were statistically less likely than whites to undergo cardiac surgery. But on the other end, if you see, there was a nationally representative survey of physicians that was found that these physicians believe that race and ethnicity were not factors in obtaining care. So we really have this chasm, right, where African Americans are not engaging in the care that they need, and you have a predominantly white medical community saying that that's not something we need to pay attention to increase access to care. So that's really important to pay attention to, that African Americans and other minorities are really struggling to access care in a predominantly white medical field. So as we still see that racial and ethnic minorities share disproportionate burdens of premature illness and preventable deaths. Also, when we think about Black professionals in the medical field, of being kind of that voice of Black patients who are underserved, we still see a threat today to their involvement in the field as a whole, because there's still a lack of funding investing in this population to be involved in the medical field, to get into the medical field. And there's still a shift away from minority health priorities, as well as affirmative action by white medical fields or schools. So now we're going to talk a little bit about how this ties into this history of health inequity. And like I said, that through line of not having access to care, mistrust in medical providers, and a lack of diversity in the medical field in general, how that is going to really impact the diagnosis and treatment of autism today in racial and ethnic minorities. So we know that there's still racial disparities within the diagnosis of autism between white children and Black and Hispanic children. I'm going to talk a little bit about the Autism Development Disabilities Monitoring Surveillance Program. This is a program through the CDC, the Center for Disease Control. And this is a surveillance program that tracks individuals who are diagnosed with autism spectrum disorders in 11 sites around the US. And they're listed here for your reference. Spoiler alert, Ohio is not on the list. But prevalence rates are are gathered from this surveillance system. That's how they get the prevalence rates of autism. So it's important to pay attention to. Prevalence rates are presented for the 2014 8-year-old children, and they focus on 8-year-old children because, according to the Metro Atlanta Developmental Disabilities Monitoring Surveillance Program, autism spectrum disorder rates peak at this age. So that's why they pay attention to those that 8-year-old age. But the ADDM estimates that the autism spectrum prevalence among children who are 8 years old in these communities of the sites that they looked at have increased approximately to 1 in 150 children during the 2000 to 2002 surveillance year, and to 1 in 68 children during the 2010 to 2012 surveillance year. So this more than doubled during that period. And as we know, foreshadowing, right, we already heard that the prevalence rates have also increased currently. But we'll get there. We'll talk about that in a little bit. The observed increase in autism spectrum disorder prevalence is consistent to other past research as well. But it really underscores the need for continued surveillance and consistent methods to monitor the changing prevalence of autism spectrum disorder over time. And just to let you know how they do the surveillance, they do 2 phases. The first phase is they do a record review of evaluations that had been done by providers in the community at those 11 sites. And they review pediatric health clinics, specialized programs serving kids with developmental disabilities, and also children who are receiving special education services through their school. Then phase 2 is trained clinicians will look at these evaluations and determine the autism spectrum disorder case status. So were these kids diagnosed with autism, or do the behaviors and symptoms that were observed during the evaluation, do they meet the criteria of autism spectrum disorder? And if they do, they're included in the surveillance system. Overall, 53,000 records were reviewed, and about 5,000 met the definition for autism spectrum disorder to include in the surveillance data. And the results were in line with previous studies, finding that Black children were older when they received an autism spectrum disorder diagnosis than white children. And Hispanic children were less likely overall to even have an autism spectrum disorder diagnosis when compared to white children. So let's look at some of the data. And again, this is 2014. We'll go to current practices in a little bit, but we really see that the prevalence of autism spectrum disorder from white to Black children is almost equal in 2014. The gap has been closing over the last several monitoring cycles, surveillance cycles, and the gap has been closing over time between white and Black children. And 1.4 was the highest prevalence period at one time, but now it's almost equal in 2014. But we see also that in 2014, the prevalence ratio had it so that white children were 1.1 times more likely to be diagnosed than Black children, down from 2012. When it was 1.2 times more likely that white children would be diagnosed with autism spectrum disorder than Black children back in the previous surveillance cycle. While having a higher percentage of white children who were identified with autism spectrum disorder compared to Black children, there was a wider gap between white and Black children to Hispanic children, which we're going to look at a little bit more in depth in a little bit. And though these differences are still smaller than when compared to previous years, the gap is closing, and they're thinking that the reduced gap is probably due to more effective outreach to diverse communities in efforts to have children screened with autism diagnosis or autism spectrum disorder sooner. But we also see that even though that the prevalence gap was closing overall between white and Black children, there were still disparities among Black children and Hispanic children diagnosed with an intellectual disability than white children. So if a child's IQ was below 70, that signified that the deficits were more noticeable or impactful to the child. They were probably being noticed and diagnosed more than if the child's deficits might not be as significant. So again, from what Karen was referencing earlier, we see that if a child might have mild symptoms of autism that aren't as notable, these kids are going to be not picked up at that earlier screening, and they're going to be missed. So there's an even more delayed onset of diagnosis for kiddos who might have average to high average cognitive functioning. But it's significant that there are more Black and Hispanic children diagnosed with an intellectual disability and autism spectrum disorder than white children. And again, here we see with Hispanic children, white to Hispanic children, the prevalence ratios are closing over time. We're still seeing that a white child is 1.2 times more likely to be diagnosed with autism than a Hispanic child. Hispanic children are also being diagnosed later than white children on average, as we're seeing with African American children as well. And a study from 2013 in the Journal of Pediatrics found minority children who get diagnosed with autism are also less likely to receive medical services, especially with regard to specialists that our kids need to interact with a lot of times, like GI doctors and neurologists. They also found that Hispanic children had lower rates of psychiatric evaluation and neuropsychiatric testing compared to white children. So these kids are not being caught, and they're also just not getting the treatment and diagnosis evaluation that they need. In another study, researchers surveyed around 270 primary care physicians in California. They surveyed primary care physicians because they're the ones who have the most frequent contact with families and play a critical role, obviously, in diagnosing autism. And they're in California because this is a state with the highest population of Hispanic children. So of those 270 primary care physicians, more than 80% offered some sort of developmental screen, and only 29% offered it in the Spanish language, which is advised by the American Academy of Pediatrics. When asked to compare the difficulty of recognizing the early signs of autism in white, Hispanic, or African American children, these PCPs said that the most difficult population to identify the early signs of autism were in African American and Hispanic children. So again, these kiddos are being missed. They're not being caught sooner by primary care physicians. This was still reported to be true even if the doctor had followed all the screening guidelines, or even if their caseload was 25% of Hispanic children or Hispanic patients. They still reported having the most difficult time identifying the early signs of autism in Hispanic children than white children. So that just goes to show you that even if they have a higher caseload of Hispanic families, they're still having a hard time identifying those early signs in this population. And they were reporting that they thought Hispanic parents were less knowledgeable about autism spectrum disorder than white parents as one of the biggest barriers, as well as not having enough access to developmental specialists, as well as language barriers and limited access to the Hispanic families, limited access to primary care. So now we move to 2016, the next surveillance year. When they conducted the program or their monitoring in 2016, this is when we see the autism prevalence rate ratio raise by 10% to 1 in 54 children that are diagnosed with an autism spectrum disorder. So it had doubled the last time, and now it's increasing by 10% again. This time, prevalence rates for Black children and non-Hispanic white children, though, were almost the same. And this is attributed to, again, more outreach to ethnically and racially diverse communities. But we continue to see a higher diagnosis of intellectual disability among Black and Hispanic children who have an autism spectrum disorder than in white children. For comparison, just so you know, the Black children who were diagnosed with ID and an autism spectrum disorder was 47%. Hispanic children with ID and ASD was 36% compared to white children who were diagnosed with ASD and ID, and that was only 27%. So we're still seeing a higher rate of Black and Hispanic children with ID and autism. Black and Hispanic children, mostly those without ID, were also continuing to get a diagnosis at a later age than white children, and white children were being diagnosed at a median age of 3 years old or 36 months. Whereas white or Black and Hispanic children were getting that diagnosis at around 4 or above. And we saw in the latest report that even the median age of diagnosis for Black children with an intellectual disorder was 6 months later than white children with an intellectual disorder and ASD. So still later. So this, again, it continues the trend of autism symptoms that are more significant in minority populations are being noticed earlier. Otherwise, if they have less impactful symptoms or less severe symptoms of autism, they're being missed compared to white children. And overall, minority children are just being diagnosed later than white children. So let's talk a little bit more about that timing of diagnosis in African American children. There was a study done in 2020 that had a sample of 584 geographically diverse African American children whose average age of diagnosis by their parent report was comparable to the surveillance data system. The delays were substantial though. So parents reported that they brought concerns of delays to their pediatrician on average 3 years before actually receiving a diagnosis. Within this sample, there was a high rate of earlier diagnosis among those who had, again, an intellectual disability. Again, it just all is in line with past research showing that children who present with higher cognitive deficits result in being caught sooner or diagnosed sooner. In this sample, the average age of diagnosis was 4 years old, which is, again, far beyond that recommended age for most effective treatments of earlier intervention that have the highest impact for treating autism spectrum disorder. So this is notable because if the parents in this sample had been listened to sooner, they could have potentially benefited from early intervention. And in this study, it shows that 42% of parents required 3 or more subsequent visits with professionals before an autism spectrum diagnosis was made, the mean age being 65 months compared with 36 months, right, for white children. The majority of children in the sample had health insurance at the time they initially reported concerns, so that was not the barrier in getting evaluated. So it's difficult really not to see this through the lens of past racial inequities in healthcare in America, with Black people really being sent away or not taken seriously in treatment and not listened to. So it kind of is pretty stark when you look at this study. What beliefs and ideas or stigmas are going to be reinforced for these patients and patients like these families based on what they've already experienced before through systemic racism. They're being turned away, they're not being listened to, and as a result, they're not getting the treatment their child desperately needs. We also see that 31.3% of parents stated that an availability of specialists was a barrier to diagnosis. So we also just don't have enough people to provide the service that they need. There were higher rates of ID among those in the sample diagnosed with autism, again, similar to what the ADDM reported. And factors that typically predict cognitive outcome were not shown to have an impact on these individuals that were diagnosed with ID. So those factors would be preterm birth, socioeconomic status, or factors that they inherited from close relatives. There's not a straightforward connection in the study between the timing of diagnosis and the cognitive outcome, but it's just notable that the average diagnosis was past the window of recommended early intervention. They're really missing that critical period because of these systemic barriers. This also suggests that Black children who are high average or average cognitive functioning but have mild symptoms of autism are not being caught sooner either. All right, Karen is now going to talk to you a little bit about the barriers to diagnosis and treatment of autism spectrum disorders and ASD within our CASD.
Thanks, Kathleen. So Kathleen did a really nice job of giving us a broad understanding of the history of health disparities into the current time frame that where health disparities and inequities continue to affect our racial and ethnic minorities in our country, and even more specifically, those individuals who are diagnosed with autism spectrum disorder. So we're going to take some time to explore some of those barriers and talk about too. She did a really nice job of kind of talking through diagnosis, and you'll see that many of those same barriers filter through or carry through to barriers to accessing treatment. So even if we are achieving better rates of identification and diagnoses, getting from point A to point B, so from diagnosis to treatment, is still something that we need to be thinking about. So we are presenting this slide here as a snapshot of the demographic data for the year of 2020 at the Center for Autism Spectrum Disorders, specifically broken down by race. So we know that all the clients that are receiving intervention at the Center for Autism Spectrum Disorders have a diagnosis of autism already. So really here we can just focus in on the racial and ethnic groups that our clients have endorsed. I want to share with you that the Center for Autism Spectrum Disorder really examined this data in the past year as a way to prompt thought and reflection, and also to really brainstorm ways to improve our access to care, to address our own existing barriers, all the way from kind of structural systemic barriers, all the way down to, clinician factors. Really so that we can provide better care and we can be better advocates for our diverse clients with autism to receive the care and intervention that they need and that they deserve. So I will just kind of orient you to our pie chart here, and you can see that as an entire center, so this is across all of our programs as a whole. We'll talk a little bit more specifically about the outpatient psychotherapy program in just a bit. But you can see that we are continuing to largely serve our white clients with autism, our white population, at 62%. We have then Black or African American clients at 17%, biracial or multiracial clients at 9%, Asian clients at 5%, Latino or Hispanic clients at 3%, African at 2%, Latino, Hispanic, white, Black, or those that endorse multiple races, as well as American Indian and Alaskan Native at 2%. So this, you can see there, it's not quite representative of the demographic location that we're in Central Ohio, but it gives us a good idea of the breakdown of the population that we are seeing and that we are serving. So let's discuss a little more in-depth barriers to treatment. Okay, so we are going to start with systemic or structural barriers, and we're going to work ourselves through this. So a systemic or structural barrier really refers to practices or policies or procedures that are put in place at the organizational level or exist at the organizational level and create a disparity or a difference in the provision of services or the access of services for a particular part of the population. You'll notice similarities to what Kathleen has presented, but what we know about the differences in information and knowledge about treatment options is that there's gaps in information that is available for our racial and ethnic minority groups. So therefore, there are differences in their knowledge about what treatments are recommended, what treatments are evidence-based, and what treatments are being offered as intervention for autism spectrum disorders. There, at the systemic level, something that contributes to this is that there are either a lack of resources to disseminate information or a lack of expectation by an organization to disseminate that information equitably across the community and to ensure that we are reaching populations of racial and ethnic minorities or those that are underserved. This really speaks to our need to go above and beyond our regular channels of connection or our regular streams of collaboration, and really focus, like Kathleen mentioned, on that outreach and making sure that we are finding ways, to disseminate our knowledge and understanding and information regarding treatment services and providing that education on the importance of our interventions and the outcomes that they can have. The other thing to note is that when we are disseminating knowledge and we are reaching minority populations and groups or those that are underserved, oftentimes the information that's being provided is not in the relevant language of origin. So if we think about too, being able to disseminate that information is one thing. Having it be in an understandable format is another thing that we need to pay particular attention to and be very culturally sensitive to. We also know that individuals and families that have a lower social economic status also have fewer resources available to them to gain this information and knowledge from. So as Kathleen mentioned, there are fewer health providers available that specialize in autism in rural and underserved areas or available to those with lower social economic status. Additionally, they have fewer cohorts or peers with autism or knowledge about autism to access for support and knowledge sharing. Overall, they can have less access just to websites and internet resources and the technology that many other racial groups access to gain information. So in particular, one study also that we looked at, that provides support for not only the issue of race, but also the issue of social economic status, is a study that suggested that Black families with a lower social economic status were found to be less aware of evidence-based treatments available for autism than Black middle-class families, suggesting, again, that difference in social economic status also contributes to barriers to accessing and engaging in treatment. So it's not just race alone, but then you begin to see the compounding layers, right, that create barriers and perpetuate some of this disparity. Additionally, we have like Kathleen mentioned, a lack of available providers, right, and long wait times. So part of this is access to care in general within the healthcare system, but then it is also particularly relevant for our racial and ethnic minority groups. There are fewer ethnically diverse professionals. There are fewer professionals in their entirety in more rural and underserved areas, which then create, limited access to those individuals that are seeking treatment and intervention. So it's important, that we are paying attention to diversifying our staff. There's also a lack of culturally competent providers. So in terms of thinking about the experiences of our racial and ethnic minority clients and families, they continue to report experiencing stereotyping and implicit bias, and even microaggressions in their interactions with their healthcare providers that are either not culturally sensitive or informed, or predominantly white, as Kathleen mentioned, how our organizations continue to be largely structured. So this is often leading to disengagement in services and avoidance of treatment seeking altogether, or potentially then early termination of services if they, are coming into care. So in particular to autism, we also need to really be mindful and thoughtful about the inclusion of neurodiverse individuals onto our staff and how they can contribute such valuable input and skills to our treatment services and to our practices. So I just wanted to make mention of that as well. Additionally, falling in line with some of that stereotyping and implicit bias, just like Kathleen mentioned, our racially and ethnically diverse families are reporting oftentimes needing or experiencing multiple appointments or multiple evaluations, or having to verbalize their concerns about autism in multiple settings in order to be evaluated or to receive a diagnosis. That is also happening with treatment as well. So our racially and ethnically diverse families are reporting requiring additional visits or seeing additional providers in order to get treatment, satisfactory and comprehensive treatment. Another thing, another barrier that exists is often organizational policies and procedures regarding who can access care and what you need to access care, and then also guidelines that outline what the participation in treatment services should look like. So some of this is driven by that overall wait time to services and access to care from that healthcare perspective in general. But it is not, it leads to the development then of more strict criteria. You have to have this evaluation. You have to have this particular, schedule or availability, or these are our limited hours. That if you would like an appointment time, these are the slots that we have, or once in care, leading to more strict attendance policies, so that we can, try to ensure that you're receiving the most amount of services or the most amount of treatment in your course of care in the shortest amount of time, so that we can continue to run, reduce wait times for other families. But oftentimes for racial and ethnic minorities that are up against other barriers that we'll take a look at in a minute, these policies make it harder for them to access care and to participate or to continue consistently through a successful course of care. So we can talk a little bit about that. Also to mention, Medicaid reimbursements remain low. So for those in rural or underserved areas where there are less available providers to begin with, we also see that if this is a common source of funding and healthcare coverage in a certain area, it is difficult to get providers to provide services in those areas to maintain that workforce and provide those treatments to our families. All right, so moving on to look more specifically at family and cultural variables, and then on to psychosocial and logistical barriers. So you can see how this is, there's lots of threads that run through all of this, through history into the current, from a broader level down to a more specific level. But some of the cultural factors that come into play are how racial and ethnic minority groups view developmental problems. So at times they can view these difficulties as less impairing than their white counterparts. They often will attribute developmental delays to age or to gender, and take the perspective that a child will eventually catch up. So for instance, the idea that, boys overall may develop in a certain area more slowly than girls, or, they are a little bit behind for their age, but they'll eventually, catch up. So sometimes that leads to less identification of those developmental issues being considered a problem, and leading into diagnosis or treatment. Again, like Kathleen mentioned, if we are verbalizing concerns about development, racial and ethnic minorities have to do that over and above the amount that other white families do. So the other thing related to this may be that racial and ethnic minority groups tend to view the cause of the problem or the impairment and attribute it differently than other groups. So the tendency to see it as a behavioral concern, or even to be told that it's a behavioral concern or have received a different diagnosis prior to a diagnosis of autism, it leads them to think that, or to blame, or to see the solution to these issues as a change in, a need for a change in parenting style, or an increase in firmness of discipline, and believe that these concerns will be eliminated if the parent is more effective at using, these disciplinary strategies, rather than thinking about, this is something that is going to be chronic over the course of time and really requires, some intervention, or can be helped with intervention. So then you think also about our kiddos who have more mild symptoms of autism, and how then some of these beliefs or views or perspectives can overlay that as well, making it even less likely that a family will engage in treatment services. So in thinking through the diagnosis of autism, like I said, they may just disagree with the diagnosis of autism as they're attributing, trying to understand what are the cause of these problems, or they may have been told that it's something else in the past, and may not have the knowledge or information or access to resources to understand the difference of what they've been told previously to what the autism diagnosis they've been given at this point, leading them, to try to figure that out. So I think, part of that then too, the mistrust or, experiencing that racial, the racism or the implicit bias or the stereotyping in their interactions with their healthcare provider often leads to feelings of being discredited or devaluing our families. And so if we think about a family who's trying to sort through what a diagnosis means or how it pertains to their child, the likelihood that they will rely on the information and ask questions to their healthcare provider may be affected. Additionally, in racial and ethnic minority groups, there is or can be some negative stigma attached to having a mental health diagnosis or a psychological problem that requires or is best treated by professional intervention through the healthcare system. So that may lead to less treatment seeking or help seeking behavior. But additionally, on the flip side of that, avoidance of negative stigma, some racial and ethnic minorities view disabilities as a part of life. And are more accepting of that diagnosis or that impairment, and feel that it should not hold a child back, that they should be treated just like any other child or any other person, and that they are just as capable and able, which we know is a very resilient, strength-based way to approach even, autism intervention. However, for racial and ethnic minorities, this may contribute to a lack of seeking treatment services overall, when we know that intervention may improve skills and best outcomes for that child. The other thing to note is that racial and ethnic minority groups tend to rely on different connections of support. So they rely on family to assist and help and inform their knowledge. They rely on social supports and community connections for guidance. Their faith-based communities or their church families are really seen and valued and prioritized as a source of guidance and assistance when problems or difficulties arise. So we see these families connecting with others and relying on others more than they connect and rely on the professional healthcare system. Looking at the psychosocial or logistical barriers, we have transportation, we have life stressors, we have family responsibilities, we have poverty and basic needs. So for some of our racial and ethnic minorities or underserved populations, they may not have access to transportation, or they may not be able to arrange transportation, reliable transportation consistently to engage in treatment services regularly. Or they may live in an area where public transportation or access to transportation doesn't exist, or that it's such a far distance from the clinic that they can't utilize it to get to the treatment services that are specialized for autism and that they need. Additionally, life stressors make consistent treatment times and schedules and engagement sometimes unachievable. So in racial and ethnic groups, childcare is a major barrier to engaging in treatment consistently. So there may be multiple other children in a household that need cared for or that have other needs, and you may have a single parent household. So anytime that parent needs to engage in treatment for one child, they also are responsible for finding childcare or meeting the needs of their other children as well. And may struggle to do that. And especially if we're experiencing poverty or basic needs are not being met, families are often taking on additional responsibilities, additional jobs. They may be providing caregiving themselves and doing it themselves rather than relying on other individuals that they may have, to pay or that aren't, that they don't trust to provide that care. And so if we are experiencing problems with maintaining housing or adequate food or adequate income, if there's financial stress, these basic needs are going to be prioritized for those families over treatment needs. Okay, so this is where I want to add in then a little bit more specific information about our outpatient psychotherapy program. So again, sharing these slides, you can see the 2020 demographic breakdown specifically for our individuals with autism that are can be primarily identified as receiving mental health services. And you can see that there are increased disparities in that, in accessing those services or engaging in those psychotherapy services. So you can see the shift, right, in our demographics. So primarily serving 82% white families, which is a dramatic increase from our general population or our general demographic slide. You can see then our percentage of families of racial and ethnic minorities decreases, so we increase in white and we decrease in the others. So we have Black or African American families at 7%, biracial or multiracial at 6%, Latino Hispanic white at 2%, and Latino Hispanic unspecified at 1%. And then we've lost some of our demographic population altogether here, where we had some Native American and Alaskan Native, and also families that are endorsing multiple races or ethnic groups. So just want to share that as food for thought. We can start to hypothesize about why this demographic may look the way that it does, based on some of the things that we've already covered and been learning through our evaluation of health disparities and health inequity and barriers. It is really a kind of stepping off point for us to really reflect and be thinking about what barriers may be impacting our overall demographics for our outpatient psychotherapy program specifically. And then on top of that, right, we'll talk a little bit more about this past year being a year of global pandemic. So, we can be thinking here, right, about the stigma attached, the negative stigma attached to seeking mental health services or being diagnosed with what is perceived a mental health or psychological problem, and then also accessing treatment services around that versus relying on other connections for support and information, or potentially viewing those things more as parenting issues or behavioral problems that don't maybe necessarily require intervention. The other thing too is, thinking about, we talk so much about early intensive intervention and applied behavior analysis, treatments for, as a recommended treatment for autism. How many families are we reaching? How many families even know that cognitive behavioral therapy is also an evidence-based treatment for reducing mental health needs or treating and managing mental health symptomology in the autism population? So how many of those families even know that our psychotherapy services exist? So thinking about our outreach efforts specifically around this, and who are we reaching and how can we do a better job? So the other piece, to be thinking about, again, is in our outpatient psychotherapy program, we're primarily seeing and treating our kids and teens that have milder symptoms of autism, who do not have intellectual or language impairments. So we know that these kids overall, we've been talking about the delays in diagnoses for both our kids with more mild symptoms of autism and without delays that are significant in early childhood, but also then thinking about the delays in diagnosis for racial and ethnic minority groups. So if we're putting those things together, we truly may be missing an entire group of kids diagnosed with autism that their symptoms are maybe not being identified, a diagnosis isn't given or until much later, or potentially at all, or their symptoms are not viewed as impairing enough to warrant professional intervention. All right, so that brings us to COVID. Because we want to bridge this into a discussion about telehealth and how that has undoubtedly changed all of our worlds as healthcare providers, but it has also prompted great reflection and great emphasis on things that we need to be attending to, as Kathleen mentioned. So before we make that jump into telehealth, we're just going to pause for a minute and take a brief look and have a brief discussion about the impact of COVID-19. On this slide, we're depicting some information and data that was gathered from a national survey conducted during the summer of 2020. And granted, this survey surveyed adults who were 18 and older rather than children. However, we know that the mental health needs and concerns for both children and adults have skyrocketed over the course of 2020 and during our pandemic. So we still think it's relevant to kind of, share this information and also talk about how it relates to racial and ethnic disparities. So the goals of the survey were to identify populations that were or are at risk for psychological distress and unhealthy coping in order to inform policies and address health inequities and increase access to resources for treatment and for addressing certain clinical populations during the pandemic. So we can see here by the information that particularly symptoms of anxiety and depression, which we also know is one of the most common comorbid, diagnoses in the pediatric population with autism as well. Those symptoms show a significant increase over time, as well as acute stress and trauma-related symptomology. And you can see there that the proportion is almost at 41%, right? That endorsed increased symptomology and distress specifically related to the pandemic. So we can really see there the impact of just the pandemic itself. Looking at the graph over here and kind of orienting you to that and to the last statement, last bullet point on this slide here, really hits home on a very important mental health concern that has really been highlighted throughout the pandemic, and that's the issue of suicidality. So you can see in this survey, almost 11% of survey responders endorsed seriously having considered suicide within the 30 days before completing the survey, which is important, but it's also a hard, thing to swallow. But it's real. And it is also relevant to the pediatric population. But if we look here in the essence of trying to identify populations at risk, we can see that the populations that were identified are racial and ethnic minority groups, and also, with the blue being Hispanic, kind of the brownish, goldish mustard color there being non-Hispanic Blacks. And then the gray is self-reported unpaid caregivers for adults. So if we think about what we've been talking about, and how many racial and ethnic minorities may fall into that caregiving category, I think it's important to note. And then here on the end with kind of our rust color, we have essential workers. So what the takeaways really were from this survey is that we really do need community-based level interventions to support kind of the ongoing needs that have arisen from the COVID-19 pandemic. We're a year in and, still struggling. So we need community level supports. We need efforts to support people economically and reduce financial stress. We need prevention efforts, and we need things that will address the stress of experiencing racial discrimination and promote social connectedness and really provide support specifically around clients and families that are experiencing suicidality or at risk for suicide and maladaptive coping. So one of the things that it also suggested is based on these populations identified at risk, we really need to be reaching our racial and ethnic minority groups with information about how to promote their own health and their well-being, and how to access services and where resources are available to help them with that. All right, so let's talk a little bit about telehealth, because that is also the other thing that has happened in 2020 in our healthcare system. So we're going to take a little bit of a deeper dive into exploring telehealth, telehealth for autism, telehealth for racial and ethnic minorities, and really add this into the equation of how we can serve our families. So what we do know specifically related to autism is that telehealth services have been utilized and researched for a while. But really, we have just emerging, and of course, within this past year, an abundance of research and information related to autism treatment, specifically diagnosis and treatment. But the literature suggests that we are able to provide telehealth services in a meaningful way across the board in the general population, but also to our clients with autism. I think this is important. The second statement here really depicts a framework that we can use. So when we think about a departure from in-office sessions to, using telehealth, it feels a bit discombobulating, right? We've all experienced that this year, I'm sure. But what we really need to be thinking about is conceptualizing it as a treatment modality for the implementation of existing evidence-based treatments relevant for the treatment of autism, the diagnosis and treatment of autism, rather than a complete diversion from the skills that we know and the strategies that we know that work, and feeling like we need to kind of redevelop or redo all of the interventions and strategies that we're providing. It's just, we are providing the same treatments that we know, maybe with some modifications and some thought put into it, but we're not, like recreating the wheel. We are just moving to a different format. And so, conceptualizing it that way, that we have the skills, right, to still provide the intervention. We just need to adapt ourselves to telehealth. So, like I mentioned, COVID has really, advanced the use of telehealth services in this past year. And I know, particularly within children's, it allows us to take a really good look, because in behavioral health, we went from providing 0 telehealth services, it wasn't a modality that had been deployed quite yet, to moving to 100% telehealth services in less than a week. So we have a very clear switchover that happened, related to the pandemic. The thought is that a certain level of these telehealth services will be maintained over time. So it does, benefit us to take a look at how that modality is working. And what we're finding is that there are several benefits associated with telehealth services for individuals with ASD. Okay, so thinking about benefits of telehealth services, the instruments and assessments that we use for accurately making a diagnosis of autism have shown to be relatively feasible and reliable in making an accurate diagnosis of autism. So during this past year in the COVID pandemic, telehealth really was an important part of keeping our diagnostic process for autism moving. If we think about, not being able to diagnose children in that critical window, and the COVID-19, contributing to additional delays in that process. Of course, some of the instruments and tests may require some modification, or parts of them may not be able to be administered just by their interactive nature. But the research and evaluation of the diagnostic practices is growing and expanding rapidly and showing, good promise. Overall, telehealth has also been viewed as researched as an effective method for the provision of treatment services for autism, including those behavioral interventions, parent training, utilizing parent coaching to implement applied behavioral analysis programs, for the provision of psychotherapy services, and care coordination services. So literature is also suggesting that these services are viewed to be just as comprehensive as in-person services, and they have a very high positive client satisfaction. So families are really appreciating the barriers that are removed from accessing treatment and engaging in treatment, based on moving to the telehealth model. And they're also reporting them to be feeling just as personable as an in-person session, although these are things, to keep in mind and still be considering. But like I said, it's likely that some version of telehealth will continue on into the future. Additionally, interprofessional collaboration and consultation has also improved with telehealth services. So children with autism, more often than not, have a team of providers rather than a single provider that is administering intervention and providing treatment services. So telehealth makes it a lot easier to pull treatment teams together, and different providers, whether it's within an agency, such as ours, if we're co-treating, or with external agencies or providers, schools, home care providers, the County Board of Developmental Disabilities, you name it, these kids have large systems. And it's a way for us to reduce travel times and scheduling barriers and cost barriers that typically exist when we're all trying to collaborate and meet together. So that has really been a great benefit as well. Okay, so telehealth through the pandemic has really allowed for increased access to services for those that live a far distance or are in more rural or underserved areas, where some of those autism-specific resources may be less available, less comprehensive, or maybe not even available at all. So it allows families to access a greater number of providers with varying different degrees of autism expertise in a lot of different areas related to the diagnosis and the interventions that are needed. And in some circumstances, it has also reduced wait times as in-person volumes and appointments may be limited due to the current health and safety guidelines, such as social distancing and taking time to disinfect, or have periods of time where clients and or staff are not present in the office and things like that. So we, particularly with our program and our services, we were able to just continue to kind of have that rolling schedule utilizing telehealth, and not have, to really reduce that volume and spread families out, again, creating more wait times and more difficult access to care. So telehealth, this is one of the client favorite barriers that have been reduced, but it removes potentially that barrier for transportation for those that don't have access, that they're traveling a far distance, or there's extensive travel times, to the clinic. Additionally, if caregivers are anxious or it causes them stress, right, to come into the clinic, or particularly traveling with their child with autism who may not appreciate the long ride or the traffic jam or the additional transition in their day, the deviation. This really makes services more accessible and more convenient. In fact, our clients with autism will report that they often enjoy the telehealth format, and it makes them potentially a little bit more comfortable as well. We can observe them in their natural environment, or even, their preferred environment, which could be at home or in their room or wherever that may be. The other thing is the reduced costs associated with treatment. So if we think about coming into an in-office appointment, we have costs related to gas, potentially caregivers taking off work or using their vacation time on treatment appointments rather than on vacations, or just other self-care, activities, childcare costs. So having to pay somebody or rely on others to care for your other children while you're bringing your child with autism into care. Additionally, if depending on the scheduling, you may have other indirect costs too, like now that we're done with therapy, we need to stop and eat, or whatever, so that we can get home in time to do this, that, or the other thing. So overall stress and cost is reduced. The other thing would be time, right? So increased in scheduling flexibility, less time taken off work, less time taken off school. For our services here at Children's, we often have families that are traveling anywhere from 2 to 4 hours just to come to an hour-long in-person treatment service appointment. So you think about a parent or caregiver needing to take an entire day off work, or even a child missing an entire day of school. That can have a significantly negative impact on a family. So now I'm going to turn it over to Kathleen, who's going to talk to us a little bit more about the cultural considerations for the use of telehealth.
Yeah, so basically technology is the most important thing when we're talking about telehealth, right? So they need some way to access a telehealth appointment. So when we look at a Pew Research data poll, 81% of adult Americans own a smartphone. Smartphones are very prevalent in our society, and I would argue are almost a basic need at this point. But if you look at the differentiation of white adults to Black adults who own smartphones, it's not that big of a difference. But most importantly, we need to really consider access to internet via the smartphone, because that's going to be crucial and a requirement when we're talking about patients trying to log into a telehealth appointment. Mostly people have smartphones now, and there's even less ownership of other tech devices like laptops, tablets, desktops. I don't think I've had a personal computer in almost a decade. So there's less reliance on those things, and now we just have this computer in our pocket. But look at that difference between the white adults who have broadband internet use and overall American adults who have broadband internet access compared to Black adults, only 85% compared to 92% and 90%. So that's going to be really important as we discuss in a little bit why broadband internet use is going to be something that we'll have to really focus on and pay attention to when starting telehealth treatment. When meeting clients and families for the first time via telehealth, it's going to be important that the provider be fluent and well-versed in the use of the technology and whatever telehealth platform they may be using, so that they can help orient their clients and families to that process. Provide direct instruction or modeling, and allowing the client to practice and become more familiar with it. I know personally, as a clinician who is not tech savvy, trying to figure that out, like Karen was saying, that very quick jump from all in person to then all over telehealth can be pretty overwhelming, and it can be for clients too who might struggle with technology literacy, for example, older caregivers or those from rural or underserved areas. Also, one of the first tasks a provider should do is ask if the patient will have access to continuous broadband internet usage in order to conduct a telehealth session. So the idea is to problem solve barriers ahead of time to have the most success. So again, we see that Black adults in America didn't have as much access to broadband internet as white American adults did. Providers also need to have an open dialogue with families about their values and beliefs regarding the use of technology, and be able to regularly assess the perceived effectiveness and satisfaction, because some might feel less stigmatized through the use of telehealth, but others might also feel that it's a less personal way to engage with a medical practitioner, and might pick up on feeling less supported in that using a telehealth platform. It might be more difficult for them to build a true connection or build rapport with the clinician. So the clinician might have to explore some of those attitudes and beliefs further, or share literature when appropriate to help families engage with that platform. But overall, there have been meta-analyses that show that there are high satisfaction and acceptability rates of telehealth in racial and ethnic minority populations. But we do have a responsibility to make sure that our clients and families understand that the platform and programs that are that we're using to access healthcare might have protection or privacy requirements. So they need to know what the risks are for breaches in privacy and confidentiality. We have to explain this in an understandable way, not using jargon, just so that we can really be open and honest and try to maintain and build trust with those families that, as we talked about before, might just, on a good day, not trust medical providers. It should also be sure to be conveyed in the client or the family's primary language. For example, at Nationwide Children's Hospital, we're able to inform clients of their sessions and their link to the session that they log in with. That information is protected, but like Karen was saying, we do a lot of co-treating and collaborative meetings. So if the family would like us to attend another meeting outside of our organization, the link that comes from that organization might not be encrypted or protected to the level that we have, and that the privacy, there might be a violation in privacy with information shared during those meetings. So taking into consideration the history of mistrust and lack of confidence that racial minorities may have for the healthcare system or a healthcare provider, it's important to understand how that plays a role in the client-therapist relationship moving forward, should there be a violation of privacy during treatment. Also, the clinician is going to be responsible for understanding the telehealth regulations and licensing requiremements based on where they live or provide treatment, and that this isn't standard across state lines. So being familiar with those to describe to the family up front. So we're going to look at some of the scheduled appointment data that we had talked about at the very beginning of this presentation. Karen went into depth and described some of that breakdown of why we're seeing such a discrepancy, perhaps, between the number of white patients we see to African American or Black patients. So you can see that just visually in this scheduled appointments and completed appointments graph. We have scheduled appointments from 2019 to compare to completed appointments in 2019, as well as scheduled appointments in 2020, which represents solely telehealth appointments compared to completed telehealth appointments in 2020. And 2019, that data represents solely in person. So we're really comparing two separate types of appointments here. So as you can see, the percentages remain pretty stable in both 2019 and 2020 scheduled appointments. 81% of white patients are scheduling their appointments. And then if we look to 2019 and 2020, those rates also are maintained about the same, 82%. But if we're looking at the transition from scheduled appointments in 2019 to telehealth in 2020, we do see a slight uptick in percentage there. As well as completed appointments, although there is a 1% difference, as there's 1% less completed appointments in 2020 from African American patients compared to scheduled appointments. But, again, we have to ask these questions. We don't really have the answer to why this may be, but we have to ask questions as to, the client population we see, our average to high average cognitive functioning. And again, those delays aren't being caught as soon in this population. And we know the African American children aren't being caught at the same early stage as white children are with autism. So again, are these deficits that are due to autism, are they being chalked up as behavioral problems? Are parents not being listened to? Or do people not have the information about, what signs to look out for? These are all questions that we have to ask. And we really need to be looking at, where is this contrast coming from? Or are kids just not getting to us for treatment? So let's look at, we're going to just kind of summarize and conclude our presentation today with some future directions of what healthcare providers can do to reduce health inequities in racial and ethnic minority populations. The first broad levels are just reducing systemic disparities in diagnosis and treatment. Easier said than done, right? But pediatricians are now more and more using the MCHAT screener, which is a modified checklist for autism in toddlers. And this has been shown to be culturally sensitive, to be administered to toddlers. So hopefully that Hispanic children and African American children those early signs will be spotted sooner. Also, we can use proven programs that reduce health disparities to create opportunities for access to autism diagnosis and treatment, including the CDC campaign, Learn the Signs, Act Early. This is a checklist for parents that have been given to culturally and ethnically diverse communities that parents can go through and check off developmental milestones to take to their provider if they have concerns. Similarly, the Autism Speaks organization has launched a Maybe campaign, and this campaign was also launched in the Spanish language. It basically educates parents to go to their medical provider with any concerns that they may have. Big or small, just any concerns about their child's development, to talk about it with a doctor. With that though, once they get to the medical provider, we need to train our staff on eliminating bias and really hiring diverse individuals who can be a good access point to families who might have a similar family of origin as medical providers, and to really kind of broaden the understanding of these racially and ethnically diverse individuals. To improve access to services, we can continue utilizing telehealth. We're all for that. After what we've presented, it does seem to be a really good option that racially and ethnic minority populations are satisfied with. And it reduces a lot of those psychosocial barriers that Karen was talking about earlier. We can also be more flexible with our policies and our organizational structure to keep families engaged in treatment. So being less strict on attendance. Another way is we can be culturally competent at a staff level. So develop and providing trainings for healthcare professionals on how to understand cultural differences and how patients interact with providers in the healthcare system. At Nationwide Children's Hospital, we have a whole committee dedicated to this and providing constant dialogue in our staff meetings every week. We can also utilize the family's strengths and resiliencies that they bring to help keep them engaged and help use in treatment to contribute to best outcomes. Also, we want to consider the cost. Again, the Medicaid reimbursement rates are low. If we can work at changing this, it can allow more providers to bill for the time needed for the complicated presentation of autism spectrum disorder. And it also allows and diversifies the amount of providers who can provide this diagnostic and treatment that we desperately need. And then lastly, we want to make sure that we are engaging in community outreach. So we want to work with other sectors such as faith and community organizations, education and businesses and transportation to create social and economic conditions that promote health starting in childhood. So really reaching out to the voices that are already loudly being heard in these communities and utilizing those to help inform and link access to care for autism. So this concludes our presentation today, but we really look forward to having your live question and answer session at the end of April.
Okay, thank you, Kathleen and Karen, for sharing your time and knowledge with us. Do you have a question you'd like to ask the presenters? No problem. as part of OPA's 2021 convention, individual live virtual Q&A sessions have been scheduled for each workshop. All you need to do is mark your calendars and plan to join us virtually on the morning of Wednesday, April 21st, 2021, from 11 to 11:45 a.m. The Q&A session will be recorded and available for those who opt to view this webinar after April 2021. To receive CE credit for this webinar, please reference the document you received when you purchased this session. Use the links in the document to complete both the online webinar quiz and the evaluation form to receive credit. CE credit will only be given if a score of 80% or higher is achieved on the quiz. Should you have any questions regarding today's educational program or the CE process, please call the OPA office at 614-224-0034. Thank you again to our presenters and to our attendees for choosing OPA to meet your continuing education needs. And this concludes today's educational program.